to manage critically ill patients with neurological and neurosurgical conditions. It's a wholly online, one-year American Association of Continuing Medical Education accredited fellowship. Physicians with critical care interest, intensivists, anesthesiologists, emergency medicine, family or internal medicine are qualified. Neurologists and neurosurgeons are also highly encouraged to join the fellowship to gain comprehensive, high-quality, well-structured education in neurocritical care. Fellows are expected to be able to lead the neurocritical care multidisciplinary team upon completion of the program. Core of the fellowship: traumatic brain injury, ischemic stroke, intracranial hemorrhage, subarachnoid and intracerebral, status epilepticus, spinal cord injury, brain tumors and post-operative neurosurgical care, neuroimaging, interventional neurocritical care skills, endovascular treatments like thrombectomy and aneurysm coiling. The program provides experience with managing non-neurological critical illnesses as well. Neuroimaging, focused training in CT, MRI, interventional neuroradiology, exposure to endovascular treatments like thrombectomy and aneurysm coiling, neurology stroke services, acute stroke management, and advanced therapies like thrombolysis and thrombectomy. Topics also include neurophysiology, critical care pharmacology, multimodal monitoring in neurocritical care, post-neurosurgical interventions care, neurotoxicology, brain infections. Become a leader in neurocritical care. Join the fellowship. Save lives. Shape the future.
Hello, everyone, and welcome to World Institute of Critical Care and Emergency Medicine Neurocritical Care webinar. The neurocritical care field is very essential, and every second counts. If we can have a proper and precise diagnosis and management early on, we can improve our patients' outcome. This is the reason that because this field is very essential, and if we don't treat our patients appropriately, we can have very bad consequences. We are focusing on making these educational activities with every month webinar to try to improve our patients' outcomes. So today we have very special webinar. We are focusing on the neuromuscular emergencies and urgencies, and we have very eminent speakers today and moderators as well. Dr. Bastian Mullen from King's College Hospital is going to moderate the session. Dr. Mustafa Gamal is the main organizer of this webinar, and he is a critical care physician at Saudi Arabia in King's Abdulaziz University Hospital. Our two main speakers today are from United States. The first speaker is Dr. Muhammad Mustafa. He is a neurocritical care physician. And the second speaker is Dr. Iman Al-Nasir, who is assistant professor of neurocritical care at Springfield, United States. So here is our agenda today. Dr. Mustafa Gamal is going to give us a brief case-based discussion of cases with neuromuscular emergencies. Then Dr. Muhammad Mustafa will give a presentation on Guillain-Barré syndrome. Then Dr. Iman Al-Nasir will talk about neuromuscular weakness in ICU. So our target is to make the neurocritical care field easier to practice and to improve our patients' outcome. So when somebody calls you to see a patient with neurocritical care urgencies or emergencies, you should not panic. And actually, it should be a straightforward practice and a fun. With that, I'm going to let Dr. Mustafa Gamal to introduce our first speaker, Dr. Muhammad Mustafa.
Excuse me, Dr. Amr will first start with case-based discussion, briefly, like 10 minutes. Then I
Yes,
will
sir.
introduce Dr. Muhammad Mustafa, inshallah. Good evening, everyone, and welcome to our new webinar in Neurocritical Care Fellowship Program. I am Mustafa Gamal, ICU physician at King Abdulaziz University Hospital, Saudi Arabia, and I'm honored to be with you over the next 10 to 15 minutes. I will briefly present 5 sample clinical-based MCQs related to our today topic and reflect the type of question you may encounter during our fellowship. First MCQ. Which neuromuscular blocker should be avoided in patients with neuromuscular disease like GBS, orchronium, vicuronium, succinylcholine, or cisatracurium? I will give you a few seconds to submit your answer in chat box.
Please share your answer in the QA box.
Correct answer is C, succinylcholine. Succinylcholine is the only available depolarizing agent. It is used routinely for endotracheal intubation and to relax the skeletal muscle during surgeries of short duration. It has a rapid onset of action, 10 to 15 seconds, and shorter duration, 10 to 15 minutes, which make it the ideal agent for these indications. Depolarization leads to loss of potassium ions from cells. Serum potassium level typically increase by 0.5 to 1 milliequivalent per liter with the administration of succinylcholine. Although it is rare, sudden rise to life-threatening levels of potassium have been reported. Succinylcholine should be used cautiously in patients with insufficient renal function, neuromuscular disease, such as GBS, myasthenia gravis, and the prolonged immobility, like in spinal cord injury, as it may trigger severe hyperkalemia. The use of non-depolarizing agents like atracurium or cisatracurium in these patients is recommended despite the slower onset of action and longer duration. MCQ 2. 66-year-old gentleman, medically free, presented to the ER complaining of progressive numbness and weakness in his legs for 5 days after an episode of diarrheal illness. He denied recent foreign travel or outdoor activities. He was not taking any medications. On examination, he was febrile, heart rate 120 beats per minute, blood pressure of 100 over 70 millimeter mercury, and a respiratory rate of 13 per minute. His neurological examination showed normal mental status, intact cranial nerves except for mild facial weakness, proximal and distal weakness in both upper and lower extremities, decreased light touch and pinprick in lower extremities and hands, diffuse loss of muscle stretch reflexes, and no sensory level and flexor plantar responses. His chest X-ray and routine labs were normal. During his medical evaluation, the patient became increasingly short of breath and was admitted to ICU after intubation. What is the most likely diagnosis in this case? A. GBS. B. Chronic inflammatory demyelinating polyradiculoneuropathy. C. Spinal cord injury. D. Multiple sclerosis.
Please also share your answer in the QA box.
The correct answer is A. GBS. Briefly, in this case, the most likely diagnosis is GBS. which is an acute immune-mediated disorder of the peripheral nervous system, usually presenting as an acute ascending paralysis. GBS is the most common cause of post-infectious neuromuscular paralysis worldwide, with an incidence between 0.6 and 4 cases per 100,000. The most commonly identified precipitant is Campylobacter jejuni. Epstein-Barr virus, cytomegalovirus, HIV, and Mycoplasma pneumoniae have all been associated with GBS also. The weakness reaches neither at 2 to 4 weeks followed by recovery, which may occur over the course of several months or be partial. Respiratory weakness and dysautonomia are potential life-threatening complications. Variants of GBS are AIDP, which is the most frequent type, AMAN, AMSAN, acute band dysautonomia, and Miller-Fisher syndrome. Miller-Fisher syndrome classically presents with ophthalmoplegia, ataxia, and hyporeflexia in a descending fashion rather than the ascending paralysis. Other options are excluded. In spinal cord injury, a spinal level is often present on the neurological examination, and patients usually have extensor blunt response suggesting corticospinal tract dysfunction. In addition, the presentation is sudden rather than progressive. Similar findings, including long tract signs, are observed in MS. Loss of reflexes is more suggestive of a peripheral nervous system disorder, although in acute spinal cord injury reflex could also be absent. The findings in these patients do not localize to the spinal cord. CIDP present with similar finding, but the clinical course is more insidious. The diagnosis of CIDP requires that symptoms are present for at least 8 weeks or more in a progressive fashion. MCQ 3. 35-year-old African-American woman presented to ER with respiratory failure, difficulty swallowing, and slurred speech. These symptoms had been present for the past several weeks, but recently worsened after she contracted a viral upper respiratory tract infection. On examination, the patient was in respiratory distress with increased work of breathing, significant facial weakness and atrophy, weak neck flexors, and severe flaccid dysarthria. Extraocular movements were intact, and her limbs were strong with normal tendon reflexes. She had seen by an outside neurologist who diagnosed her with seronegative myasthenia gravis. Which of the following study is useful to confirm her diagnosis? A. GM1 antibody. B. Muscle-specific kinase antibody. C. GQ1B antibody. D. Striational antibody. Submit your answer, please. Correct answer is B. Muscle-specific kinase antibody. This patient has myasthenia gravis associated with anti-MuSK antibody. 40% of seronegative myasthenia gravis patients who test negative for acetylcholine receptor antibodies have MuSK antibody. Myasthenic patients with anti-MuSK antibodies are predominantly women and have several distinctive features, including prominent facial weakness and atrophy, significant pharyngeal and respiratory involvement with frequent crisis, and good response to plasma exchange for acute crisis and rituximab for long-term immunosuppression. Question number 4. For patients with myasthenic crisis in the ICU on mechanical ventilation, which of the following statements is true regarding initiation of steroid therapy? High-dose steroid should be avoided because it can cause transient worsening of the myasthenia. High-dose prednisone 60 to 80 mg BO daily should be initiated in conjunction with plasma exchange or IVIG. Steroid should be started at the lowest dose possible and slowly titrate up to alternate day dosing of 60 to 80 mg once daily. IV methylprednisolone is the preferred drug since prednisone tablets cannot be given via big tube. Submit your answer, please. The correct answer is B. High-dose prednisone, 60 to 80 milligram BO daily, should be initiated in conjunction with plasma exchange or IVIG. A high-dose initiation therapy is recommended for patients in myasthenic crisis who are already in the controlled setting of an ICU and on mechanical ventilation and in need of rapid improvement. This should be done in parallel with IVIG or plasma exchange because high-dose corticosteroid can cause transient worsening of the myasthenic symptoms. Last question, question number 5. A patient who was previously diagnosed with myasthenia gravis is in the emergency room with respiratory insufficiency and altered mentation. His bedside spirometry values are as follows. Forced vital capacity 1.6 liter. He weighs 83 kg. Negative inspiratory force is negative 18 centimeter water. Peak expiratory flow is negative 35 centimeter water. His oxygen saturation is 95% on room air. What should be done next for this patient? Intubate the patient immediately for airway protection. Obtain a stat ABG as bedside spirometry is not as accurate at predicting respiratory failure. Place the patient on high flow oxygen using non-breather mask. Observe the patient closely with forced vital capacity and negative inspiratory force every 2 hours, and intubate once forced vital capacity drops below 15 milliliter per kg. Your answers, please. The correct answer is A. Intubate the patient immediately for airway protection. Indications for mechanical ventilation in myasthenia gravis patients include forced vital capacity equal or less than 15 milliliter per kg, negative inspiratory force equal or less than 20 centimeter water, or peak expiratory flow equal or less than 40 centimeter water. One should not wait for the ABG to become abnormal before securing the airway because this occurs late in the course of myasthenia gravis crisis after the patient has already decompensated. Thank you for joining and see you next webinar.
Thank you so much, Dr. Mustafa, for this very nice case-based discussion. And now we are moving to our next speaker, Dr. Muhammad Mustafa Abdul Hayy, and Dr. Mustafa is going to introduce him.
Good evening, everyone. Welcome to our new session today. It is an honor to introduce first speaker, Dr. Muhammad Mustafa. He's a neurologist from Egypt with a special experience in neurocritical care and stroke, working at Oxnard Medical Center, New Orleans, Louisiana, USA. Mic is yours, Dr. Muhammad.
Assalamu alaikum wa rahmatullahi wa barakatuh. Bismillahir Rahmanir Rahim. Good morning, good evening, good night, wherever you are. Tuna, we are going today to talk about Guillain-Barré syndrome or acute inflammatory myelitis neuropathy, is the most common variant. I would like to thank Dr. Mustafa and Dr. Amr for including me in this talk on behalf of the World Institute of Critical Care and Emergency Medicine. I personally consider Guillain-Barré syndrome as a common and a rare disorder in the same time. It's very rare syndrome if you compare it to the other neurocritical neurologic syndromes as compared to stroke, epilepsy, status epilepticus, and other neurologic emergencies. However, it's considered the most common cause of acute flaccid lower motor weakness after polio eradication. Incidence is 1 to 2 per 100,000 persons per year. It's a highly treatable disorder with a mortality rate 2% to 10%, and it can escalate up to 20% in less developed countries if the immune treatment is not started early within 2 weeks. That's why I feel strongly this order should be known by heart to everyone. So we're going to talk a little bit about rapid recognition, how to get it diagnosed by bedside criteria, a couple of builds about lab and CSF findings, electrodiagnosis. We're going to talk about indications for ICU admission and intubation, followed by immune therapy, and then we're going to go talk about prognosis and scores, followed by special situation and future horizons. Of course, I cannot cover every single aspect of Guillain-Barré syndrome in 20 minutes, but hopefully can cover the most important points that every physician must not miss. So talking about rapid recognition of Guillain-Barré syndrome, let's remember together that Guillain-Barré is a monophasic problem, and it's derived by transient humoral attack against glycosylated non-protein antigens with toll-like receptors and other inflammatory markers on hand. Let's spend some time reading about the first case scenario. As a 45 years old man presents with progressive bilateral leg weakness that began 3 days ago and has now ascended to involve his arms. He reports numbness and tingling in his hands and feet. 2 weeks prior, he had gastroenteritis and diarrhea. On examination, he has symmetrical weakness, 3/5 in lower extremities, 4/5 in upper extremities, and a reflex in all limbs. And the question is not here about Guillain-Barré syndrome. Of course, this is a classic presentation of Guillain-Barré syndrome. There is an antecedent of viral respiratory tract infection, and there is a progressive weakness in more than 2 extremities, less than 4 weeks, and there is no clue for any other diagnosis that's possible, and there is areflexia as well. So all these criteria, they are considered on clinical bedside as Guillain-Barré syndrome. But the question here, what is the most likely preceding infection in this patient? So given that this patient came mainly with weakness and areflexia, and there was gastroenteritis, so most commonly it will be Campylobacter jejuni. And Campylobacter jejuni is considered as one of the most common related antigens to one variant of Guillain-Barré syndrome, which is acute motor axonal neuropathy, amen, as we're going to know later in these coming slides. So a couple of talking back about physiology, that Guillain-Barré syndrome, a mechanism of injury is by molecular mimicry or post-infectious autoimmune problem. So for example, infection most commonly, or less commonly, tumor, checkpoint inhibitors, surgery, and some sort of immunocompromised state. But most commonly, there is a latent period up to 6 weeks of some infection, including mycoplasma, cytomegalovirus. There was a couple of outbreaks in Zika virus around the end of the early in the beginning of the century. And with all these infections, the immune system, the innate system, especially the humoral immune system, will trigger the release of antibodies from the plasma cells, which by attacking the antigens of this virus will attack other targets whose molecules are glycosylated proteins consisting of ganglioside and carbohydrate portion, and they are situated at the nerve terminals, especially around the nodes of Ranvier and the paranodal and juxtaparanodal areas. So when these antigens are attacked, they can cause either demyelination or secondary axonal injury, which is axonal injury. If they're affecting peripheral nerves, it will be whether motor or axonal neuropathy, demyelinating or motor. If they do affect the cranial nerves, it can cause ophthalmoplegia. If they do affect the cerebellar or sinusocerebellar nerves, it can cause ataxia. And if it affects the reticuloactivating system, can cause encephalitis-like picture, which is a Bickerstaff encephalitis. Guillain-Barré syndrome is one of the interesting autoimmune syndromes. It's not like other autoimmune syndromes where they do respond to corticosteroids. Unfortunately, Guillain-Barré syndrome doesn't respond well to corticosteroids. However, it responds very well to IVIG and Plex, which is kind of weird. Also, Guillain-Barré syndrome is a monophasic disorder. In 2 to 5% of the cases, it may recur, but most of the time, it's just a monophasic illness. So still a lot of research is going in Guillain-Barré syndrome itself as what exactly happens during the injury and what triggers the infection in general. And one last thing we need to consider very well, that complement injury is well evidenced in Guillain-Barré syndrome, and this is one of the future targets of therapeutic trials undergoing the way now. So, which feature is not typical of Guillain-Barré syndrome? Is it ascending weakness, hyperreflexia, sure, sparing or nerve conduction study, or albuminocytologic dissociation? Of course, the answer will be hyperreflexia. So, areflexia, given that Guillain-Barré is affecting the peripheral nerves, it typically causes hyperreflexia or areflexia, except in children where it can spare sometimes some reflexes, but it will be hyperreflexic as well. And of course, one of the most important criteria to consider Guillain-Barré is exclusion of any other mimics like spinal cord lesion, toxins, porphyria, Lyme disease, HIV in seroconversion phase. So this is very important. But having hyperreflexia would be question mark against Guillain-Barré syndrome, especially in the absence of loss of consciousness. If there's a loss of consciousness, you can consider Baker-Stuff encephalitis, but hyperreflexia in an awake patient, should consider an alternative diagnosis as a Guillain-Barré syndrome. And in these cases, MRI spine will be indicated. And there are a lot of criteria for diagnosing Guillain-Barré syndrome. We have the Anindis criteria, the Brighton criteria, and the international criteria. And the nutshell of all these criteria, the most common thing as in all these criteria is the presence of weakness of more than 2 limbs in less than 4 weeks, with diminished tender reflexes and absence of any alternative explanation. And the lab criteria are mainly supportive. So whenever you find all the main required features, as you see in this slide, that's adequate to diagnose Guillain-Barré syndrome. However, in some questionable cases, when all the criteria are not met, sometimes you may consider checking the CSF for albuminocytologic dissociation, or checking antibodies in certain cases like Miller-Fisher syndrome, or checking nerve conduction studies. But again, all these criteria are supportive, not definitive. Why? Because you do have a lot of false negatives, which we're going to talk about soon. And again, this is a differential diagnosis of Guillain-Barré. I'm going to reserve them for my colleague, Dr. Iman. And by the way, she is an amazing neurocritical attending, and I was honored to be supervised by her before. She will tell us more details about systemic Guillain-Barré syndrome, so I would prefer to let the differential diagnosis talk to her. Now, with this question, let's see what we are talking about. The mimics of Guillain-Barré syndrome. A 38-year-old woman presents with acute onset of ptosis, diplopia, and ataxia over 2 days. She had areflexia, but no limb weakness. She had an upper respiratory infection 10 days ago. So again, is it myasthenia gravis? Of course, there is no fluctuation, so it's not myasthenia gravis. Is it brainstem stroke? Brainstem stroke would have altered mental status and hyperflexia, which is not the case right here. Will it be botulism? Botulism actually will have some sort of GI illness, some sort of pupillary stuff, and there will be some sort of decremental repetitive nerve stimulation, which is not shown here as well, and there will be GI symptoms. So the only left differential is Miller-Fisher syndrome, which is very important. Differential Guillain-Barré syndrome represents with a triad of ophthalmoplegia, ataxia, and peripheral neuropathy. And this syndrome is very important to recognize that it is associated with anti-GQ1B antibodies. And if you remember, the GQ1B and the GM1 and molecules, they are the gangliosides molecules, which can be mistaken by the immune system as the targets, the viral or the bacterial epitopes. And one interesting thing about this syndrome that it's the only syndrome in which you can do the antibody testing, and it can help in diagnosis because it's 100% specific. However, the sensitivity is not that great, to be honest, but it's recommended that whenever you suspect Miller-Fisher syndrome, this is the only variant that it can declare itself over the antibody test in case it turns out to be positive. And then another case scenario is a 10 years old with refusal to walk, normal reflexes, and axonal nerve conduction study problem, but most likely has, of course, Axonal nerve damage, motor symptoms, and normal reflexes will be questionable against Guillain-Barré syndrome. However, in children, you should know that sometimes there could be some retained reflexes, and still this case can be acute motor axonal variant, not acute inflammatory demyelinating neuropathy. So this is the time now to talk about the variants of Guillain-Barré syndrome. So the first variant that you should know, the most common variant, which is the acute inflammatory demyelinating neuropathy. And it's very characteristic, the ascending pattern of weakness in all four extremities, preceded by sensory symptoms and motor manifestation. And there will be the presence of nerve conduction abnormalities, followed by the axonal damage variant, which is the axonal motor variant only, or sensory variant only, or acute sensory motor axonal variant. So the AMAN is acute motor axonal neuropathy. The ASVAN is acute sensory motor axonal neuropathy. And then Miller-Fisher syndrome is very important to consider with irreflexia, ataxia, and ophthalmoplegia. There are a couple of regional variants that you should be aware of. If some people do present with bilateral palsy and paraparesia, some people may present with pharyngocervical variant, and they may mimic polymyositis and myasthenia gravis. Some people, they may have a spinal cord compression mimic with paraplegia. And lastly, it's one of the rare syndromes of Stich-Pickel-Stafford and stem encephalitis we do see in children, and it should be considered in case of ataxia, followed by disturbed level of consciousness and hyperreflexia. And again, to recap, all of these syndromes, some of them are associated with certain antibodies that can be tested in the serum, but it's limited value in routine clinical practice because 30 to 80% are negative. And the only exception is the Miller-Fisher syndrome, in which the anti-GQ1B is 100% specific. However, it's not only found in 5% within this Guillain-Barré spectrum. And the reason why these antibodies are not detected in most of the cases, because either they are intraneuronal, not in the serum, or they are being cleared only, and most of them disappear within 6 months. They peak up in 4 weeks. And this is again a recap of all the variants of the Guillain-Barré that already discussed. And again, as another question about Miller-Fisher syndrome, this is just to remind you that the anti-GQ1B is a syndrome that is associated with Miller-Fisher variants. The other syndromes not quite sensitive specific for the AIDB or AMAN. That's why we are not routinely testing them. And coming to the lab and CSF bureaus that you should be aware of, we have a case of hyponatremia 128 on the day 3 of Guillain-Barré related weakness. What is the best mechanism of treatment? Is it fluid restriction? It would be related in case of SIADA, or 0.9% saline bolus, given that the fact that it could be hypovolemic hyponatremia, or Lasix, or solumedrol therapy. So the best answer would be fluid restriction. And the reason why this answer is a correct answer, because 30% of Guillain-Barré cases, they may have some sort of syndrome of inappropriate antidiuretic oscillation. So these cases are not hypovolemic, they are not hypervolemic, they're just euvolemic hyponatremia. And it's not a disorder of sodium, it's a disorder of excessive retention of water because there's excessive inappropriate action of antidiuretic hormone. And that's why fluid restriction will manage the hyponatremia. And this is very important and common association in neurocritical syndrome as well. And in case of severe hyponatremia, you can give the 3%, but we only reserve it only for severe symptomatic hyponatremia. And we should avoid any fast correction to avoid osmotic demyelination syndrome. Now coming to the albumin monocytologic dissociation or protein cell dissociation. What is the definition of this? Is it the elevated protein with white count more than 50, less than 50, less than 5, or elevated protein with elevated glucose? And of course, the best answer will be elevated protein more than 45 with white cell count. Usually it's less than 5 millimeter, but sometimes it can reach up to 50, but never greater than 50. If greater than 50, then you should consider something else rather than Guillain-Barré, which could be Lyme disease, HIV seroconversion, or lymphoma. And the reason in this picture why this high protein low cell happens, because of something called the subarachnoid block, which happens when there is a lot of autoimmune production um, out of the plasma cell activity, and with a lot of antibodies and a lot of protein reduction blocking the subarachnoid space. That's why there is no much of increased cell production or pleocytosis. And this case illustrates one or what something we call C-safe timing trap. So we have a 52 years old woman develops ascending paralysis over 5 days, and LP has been performed on day 3, which shows a normal protein, which is 35, normal goes 65, and 2 white cells only. So what is the most appropriate interpretation of this C-safe finding? Is it a normal protein excludes Guillain-Barré syndrome? A normal C-safe protein is common early in disease course, where the patient has bacterial meningitis or repeat lumbar puncture is contraindicated. And of course, the right answer will be that normal protein does not exclude Guillain-Barré syndrome, and it can happen early in the disease course up to 1 week. So this is something you have to be very familiar about, that the sensitivity of LP for detecting the albuminocytologic dissociation is 80% at 2 weeks and 50% within the first week. So either to repeat the nerve conduction study, repeat the LP, or do a nerve conduction study. And again, we face the same problem with the nerve conduction study because it can be negative up to 2 weeks, except in some cases. This is again recapping of the first week of Guillain-Barré, which is a troublesome point that we may find a normal LP, normal nerve conduction. The only thing will be is a high clinical suspicion on exams. That's why, again, we repeat that Guillain-Barré syndrome is a clinical diagnosis, and it should always be. Sometimes MRI can be done for ruling out spinal cord compression, and it can show some nerve enhancement in cases of Guillain-Barré syndrome. However, this is not a sensitive finding as well. For electrodiagnosis, if we recall from the variants that we have in Guillain-Barré, that we can have demyelinating variant or axonal variants. So which findings best supports acute inflammatory demyelinating bone neuropathy, which happens in 85% of the cases? We have low compound motor action potential or short sensory nerve action potential present, and abnormal median sensory nerve action potential, or absent sensory nerve action potential, or normal F waves. I give you 5 seconds to answer. So the correct answer will be P, which is short sensory nerve action potential present and abnormal median SNAP. And the reason beyond that, because Guillain-Barré has a tendency to affect some cranial nerves, which is namely the median and ulnar nerve, and sparing the sural nerve. And in the demyelinating variant, it tends to cause some classic features of demyelination, which is prolonged distal latency, prolonged F wave, because you remember is a nodal franvier and the Schwann cells secreting the myelin is a reason beyond the saltatory conduction. So in the saltatory conduction of the lost, all the nerve vesicles of different conduction velocities, each one will do an action potential at its own pace. So we'll have temporal dispersion, which see like multiple waves for the same one action potential. And you will see prolonged distal latency from the stimulation till the action. If you measure it from the nerve proximal and distal to certain areas, there will be a big discrepancy and delay in conduction velocity and the conduction block, sparing the sural nerve. And again, this is one example. It shows you in the first week, there's a temporal dispersion, as you see right here. There's a increased distal latency periods. As you see in this slide, you should be familiar with how to interpret these findings in the different nerves in your reference book. And as you see here, that there will be a conduction block over time. As you see, there is more than 50% reduction in the compound motor action potential. And during the recovery, the compound motor action potential will go up again. And this case has a normal sensory nerve conduction potential. So we think this patient has an AMAN syndrome, which is associated with Campylobacter jejuni infection and anti-GM1 antibodies. And if you do see right here, there is another important finding not mentioned in this slide, but we have an abnormal early abnormal radicular responses, which are considered as H reflex and F wave. And there is not enough time to explain the pathophysiology beyond it, but you should be familiar with absent F wave and absent H reflex. They are very highly sensitive of Guillain-Barré syndrome because of the polyradiculopathy affection in these diseases. This is another case as well, and you can see very clearly the temporal dispersion, the increased distal latency, as well as the recovery of the amplitude of the axon potential over the time, in addition to conduction blocks that we have seen in the previous slide. Again, another question about subtypes defined with the nerve conduction study. If you find a patient with compound motor action potential only of 1 micromillivolt, which is quite low amplitude, but however have a normal snap potential, which is 8 microvolt, and no temporal dispersion, which means that the Schwann cells is intact and the meninges is intact. So which subtype you think it's present? So of course, no dispersion, so there is no demyelination, so it can be AIDP. So it's either AMSN or AMN. So given that there is a normal SNAP, normal sensory nerve action potential, and only motor affection, so it will be most likely acute motor axonal neuropathy. And this is very important for prognostication because most cases of MNs, they do not respond very well to IVIG or PLEX. So you will not be surprised if you don't respond quite well. It's helping in prognosis as well, as we are going to see in the coming slides. But IIDB usually responds very well to IVIG and PLEX. Going forwards into the management of Guillain-Barré syndrome, so management will be supportive and specific. For supportive management, you have to know that 25% of the cases they may require intubation for respiratory failure or blood dysfunction, and also they may require ICU admission for autonomic disorder, which can range from sinus tachycardia, bradycardia, either tachyarrhythmia or bradyarrhythmia, or even hypotension or hypertension, and it can be fatal. So we have a 60-year-old man with Guillain-Barré syndrome admitted on day 4 of progressive weakness. Has 2/5 strength in all extremities. It's very important. It's quadriplegia. So this is the first warning sign. He's 60 years old. This is the second warning sign. And of course, I forgot to tell you that Guillain-Barré syndrome most commonly affects people as they grow older. So people most likely to be affected at around 60 years. And these are the subcategory of people that they have more complications of Guillain-Barré, including higher risk of mortality and death. So vital capacity is 45% of the predicted only, which is quite low. He develops episodes of bradycardia, which is autonomic neuropathy. So of course, this patient must be admitted to the ICU for respiratory failure and autonomic dysfunction. Again, while these patients are admitted to the ICU, we have to make sure they get spirometry at least Q4, and they get neurochecked at least daily, and they get immediately the immune therapy, including IVIG or PLEX, depending on the availability in the institution. And one of the common questions we tend to ask is which parameter is earliest to signal respiratory failure. In these people, you have to be very, very aggressive and sensitive to when to intubate this patient. Even if they are wide awake, talking to you, you may even intubate them for only vital capacity drop. You should not wait until the PCU to rise. It will be too late. You should not wait till the patient be hypoxic. Pulmonary symptoms per se, they are not an indication for intubation. If they are mild, they can get well with it. If they are severe, however, and the patient can't protect the airway, it will be a second indication for intubation for airway protection. And again, it's classified as the Erasmus Aegis score, which is a predictor score of people who will require ventilation. It's categorizing them using the onset, the Bulbar score, and the degree of weakness. And the vital capacity cutoff for intubation is 20 ml per kg. And some institutions, they may do less than 15, but I prefer to be on the sensitive side. And one thing you can remember is the 20, 30, 40 rule. So by this rule, if you have a patient with low forced vital capacity, or people with decreased negative inspiratory force, which is less than negative 30 centimeter, and MAP, maximum expiratory pressure of less than 40 centimeter water, indicating more cough clearance. And another example to show you is that you have to be very aggressive in this patient. A patient coughs after every sip and vital capacity is only 18 ml per kg. What is the next step? Of course, is going to be ICU and intubation, even before the IVIG. Now, regarding to the autoimmune therapy, so one of the good things about Guillain-Barré syndrome, they are responding very well to immunotherapy, either by IVIG or PLEX. and it can improve the capacity for people to walk after the treatment up to 45% at 4 weeks, 70% at 3 months, and 81% at 6 months. So we have a 45 years old patient with progressive Guillain-Barré syndrome, started on IVIG, which was the following statements regarding initial service correct. So adding plasma exchange to IVIG significantly improves outcomes, or IVIG and plasma exchange are equally effective, or steroids are first line, or treatment should be delayed until CSF protein rises. And of course, the right answer will be that IVIG and plasma exchange are equally effective, and steroids have never been proven to be effective in Guillain-Barré patient, and there is no preference to IVIG versus PLEX versus combination. They are all the same efficacy, and the evidence beyond that comes from multiple trials, including the Dutch Guillain-Barré study, enrolling 147 patients in 1992. And as you see in the Kaplan-Meier curve here, they have equal prognosis. It didn't matter with PLEX or IVIG. In another trial, which is called the exchange syndroglobulin Guillain-Barré syndrome, it has conducted over 383. So based on this, all these trials have been conducted in a randomized way. The practice guidelines in 2003 has proved that IVIG or PLEX can be done with equal efficacy and safety. And the only reason you should pick up which modality is the safety concern, the specific side effects that you are worried about. So, for example, IVIG is contraindicated in people with IgA deficiency or a history of severe allergy, and PLEX is contraindicated in people with hemodynamic instability. You should be familiar with the side effects in IgA, which is IVIG, which is fluoride reaction, and for PLEX, it will be the catheter-related complication because you need to insert a special central line for that, in addition to electrolyte imbalance and hemodynamic instability. And the second reason you should pick up the modality of treatment is the availability at the country, because unfortunately, many countries in the low or the middle income countries, people may die because of lack of early initiation of treatment. So whichever treatment is feasible and present. In Egypt, for example, I remember that PLEX was much way cheaper than IVIG. But here in the States, working with old patients, they do, most of the time, you do with IVIG because they are more hemodynamically stable in terms of side effect. But even with people who had PLEX on, the efficacy has been the same. It's only the safety and the availability within your institution is the key for a choice. And one thing that I should let you know, that some people, most of the people, they tend to improve. However, some people, they may not respond very well. They may relapse, which happen in 2 to 5% of the cases. It's called treatment-related fluctuation. In this case, it's okay to try a second course of the same treatments that are being used. So, for example, if have been using IVIG, you can use IVIG. If you have been using PLEX, you should use a PLEX, but it's strongly discouraged that you switch to another modality. For example, switching to IVIG and people who have been trying PLEX was the opposite. It didn't prove to improve the outcome. Unfortunately, it has proved to worsen the outcome, especially in thromboembolic complications. And it would be reasonable for people who do not respond at all, even to the second immunotherapy course, to consider alternative diagnosis, as we said earlier, and even test for autoimmune nodopathies like the anti-coctin A, contactin 1A associated protein complex, because it can be one of the IgG4 or the other autoimmune disorder complex. And the indications for IVIG, not everyone will need IVIG. For example, if the patient is able to walk, able to run, just mild sensory symptoms, of course, the benefit, the risk will be high with immunotherapy as compared to the benefit. But people who cannot run, who cannot walk, who have bad bulbar dysfunction, have like worsening symptoms or rapid progression of symptoms, they do require to have IVIG, especially in the first 2 weeks, because outcome has been proved very well. People who are able to walk but can't run, like in the Guillain-Barré syndrome disability score, They do not require the 4 to 5 plasma exchanges routinely done in Plex. You can only have 2 exchanges, and that would be okay as well. Again, for therapy timing, which statement is correct, is steroids hastens recovery. IVIG is superior to plasma exchange. Start IVIG within 2 weeks, or plasma exchange after 8 weeks is useless. Of course, starting IVIG or Plex within the first 2 weeks is very important, has proved to improve the clinical outcome. And again, the dose of the IVIG is 2 gram per kg divided over 5 days. So it will be 0.4 gram per kg for every single day. And for PE plasma exchange, it will be 5 exchanges of 1 to 1.5 plasma volume, except in people with disease with low disability score, as we already mentioned. Patient who's non-responsive after full IVIG, what is the best evidence-based option? Is it the third, second IVIG or high-dose steroid observation? And of course, it will be the second IVIG trial. And this is expected in some patients, they may worsen. Here, it's very important to differentiate who are people who have treatment-related fluctuation or lack of response, that it can happen in 2 to 5% of the cases, versus people who have Guillain-Barré syndrome mimic, which may require further investigation and may require the autoimmune nodopathy workup. So you have to be very, very careful about evaluating and re-evaluating the patient at that time. Children and patients with Miller-Fisher syndrome, there is no specific randomized control trial for them, but we tend to treat them the same as AITB as well. And for these people who tend to relapse, the future treatment, as we're going to see, has been addressing the complement blockade or tackling the IgG that's attacking the ganglioside, especially in the FC portion. So we're going to talk into this in the ongoing trials. For prognosis and scores, which is a very common question, you should be familiar how to answer it. So we have a 35-year-old woman, have Guillain-Barré syndrome. She was intubated. She had 5-day course of IVIG. It was done early, and the family inquiring about recovery. What is the most common answer? All patients for recovery was IVIG treatment. Of course, this is not the right answer. Approximately 20% can't walk independently 1 year. Recovery always occurs within 3 months. Mortality is less than 1% of moderate treatment. So the best answer would be that approximately 20% cannot walk independently at 1 year despite treatment. But the good news is that most of the people are able to walk independently. So 5% die, 20% cannot walk independently 1 year, but 80% up to 80% they were able to walk on their own, depending on prognostication score we're going to discuss now. A patient who is 70 years old, no diarrhea, with modified Rankin's, was Royal College score of 4/5. Predicted ability to walk at 6 months will be 30%, 60%, 85%, or 100%. For this case, we have to use the prognostication score, which is the EGBS outcome score, or for abbreviation EGBSO. It using the diarrhea, the MR, modified Rankin, the Royal College of the membership of Royal College weakness grades, and at day 7 to predict the ability to walk at 6 months. If the score is more than 6, it will be 90% able to walk. If it is less than 3, it will be 30% to walk. In this patient, it's an intermediate score given the age and given the early initiation of IVIG. And this is again demonstration of the modified Erasmus score. So patients who have those scores are able to walk 95% at 6 months, down to 50%, and then down to 15%. Which factor predicts chronic disability? Is a very common question. Is it the myelination, low vital capacity, AMAN with unexcitable nerves, or IVIG within a week? And of course, the right answer will be severe axonal loss, limited regeneration. So axonal subtype, as we mentioned, unexcitable nerves, intubation within 1 month, and old age will predict high risk of long-term disability. And of course, Guillain-Barré is not only about respiratory failure and autonomic problems. The long-term sequelae will be the weakness, the pain sensation, the psychiatric reaction, and fatigue, which is very, very common in cases of Guillain-Barré syndrome. And we have to be familiar how to treat and pick up the right treatment. For example, it would be unreasonable to treat with tricyclic antidepressant cases of arrhythmia. You would use gabapentin or pregabalin for peripheral neuropathy, for example. In a specific situation, I have a patient with Guillain-Barré walks 10 meters at week 3 following IVIG, then needs wheelchair at week 8. So this is considered as a worsening of the initial Guillain-Barré presentation, which again, within as long as it's less than 8 weeks, we can consider it as a treatment-related fluctuation or TRF Guillain-Barré, which can be treated by IVIG repeats. However, if it extends beyond 8 weeks, then we are going into the realm of CIDP, which is a chronic inflammatory demyelinating neuropathy, which has a different way of treatment, response to steroids, we need some sort of disease-modifying agent to spare as a steroid-sparing agent, and some cases they may require monthly IVIG therapy. And finally, with the future horizons for these cases, which target complements IVIG is a B-cell depletion complement inhibition, steroid receptor calcium channel. Of course, the right answer will be complement inhibition. As we remember, complement involvement with the membrane attack complex has been incriminated in these cases, and maybe attacking the complement C5, which is a major initiation of macrophage attack complex, membrane attack complex, or tackling the IgG, causing the nerve damage, especially the FC portion. There are the future treatments in addition to DH or DH inhibitor. However, and proton tyrosine kinase receptor inhibitor. However, the big barrier for these trials undergoing the way now is the cost, especially in the low and middle income countries. So right now, IVIG and Plex are the gold standard treatments. Finally, this is a recap of all what we have mentioned, including the blood workup, especially to check for mimics and rule out the hyponatremia. CSF finding with limited sensitivity in the first week, and when there is a leukocytosis, there is a leukorrhea, especially more than 50, you should rule out HIV malignancy and Lyme disease. The nerve conduction criteria, more than three features across 2 nerves, and the sure sparing variant. Indication for intubations, the 20-30-40 rule, the clinical course, the modified Erasmus Guillain-Barré outcome score, and the doses of the IVIG in Plex.
Thank you so much, Dr. Muhammad Mustafa, for this very nice presentation. And we'll take the question after the 10-minute presentation of Dr. Iman. Dr. Iman Al-Nusayr is a neurocritical care physician at Springville, Oregon, USA. She was the Dr. Muhammad Mustafa attending in his training in the past. And we will enjoy her 10-minute presentation on neuromuscular weakness in ICU and critical care illness, myopathy, and neuropathy.
Hello, everybody. I'm Iman Al-Nusayr, one of the neurocritical care physician, and I will talk in this presentation about neuromuscular weakness in ICU, mainly about myasthenia gravis crisis, and also I will talk about critical illness neuromyopathy. I will spend 10 minutes in each topic, and I will focus on the management and the things that we use in the ICU. I will not focus in the pathophysiology. In this slide, I will talk briefly about the classification of myasthenia. There are multiple types of myasthenia. The main type that we always talk about is the antibody that is produced against acetylcholine receptor, and this receptor is presented in the postsynaptic cleft, as we can see in the picture. There are other types, mainly anti-MuSK receptor, and this receptor is presented in the also postsynaptic cleft, and it helps in the recruitment of the acetylcholine receptor. There is also anti-LRP4. It's also attached to the MuSK receptor, and it helps also in the recruitment. The other types are related to the thymoma, present or absent, or also seronegative myasthenia. When the myasthenia patient reach the ICU, it means they are either in myasthenia exacerbation or myasthenia crisis. Exacerbation, it means that the symptoms of the myasthenia is more pronounced, like the patient is having difficulty in speech or difficulty in swallowing or double vision or um, eye droopiness or even shortness of breath. But when the patient in myasthenia crisis, it means they have severe respiratory distress that they need uh, uh, either non-invasive support or intubation. So usually if the patient come to the ED with a myasthenia exacerbation or crisis, there are things that trigger this crisis. And uh, the the things that trigger the crisis are many, but I will focus in most common things, which is usually infection. It's either they come with upper respiratory tract infection or pneumonia or UTI. There are also some common medication that can exacerbate the myasthenia crisis, and the list of the medication that can exacerbate myasthenia are a lot. But again, I will focus on most common things. So these patients, when they have infection, they will go to their primary doctor or internal medicine doctor, and then they will prescribe for them an antibiotics that can exacerbate the myasthenia. And the most common use of antibiotics that can exacerbate are azithromycin or levofloxacin or ciprofloxacin. Um, so azithromycin and levofloxacin used commonly for pneumonia, and cipro can use for UTI. There are also situations where the patient has a heart issue and they will prescribe magnesium, and magnesium is known to exacerbate the myasthenia crisis or make the symptoms worse. So there are also other situations that can trigger the myasthenia, which is usually the tapering of the steroids. So most of the myasthenia patients are on long-term steroid, and then when their doctor taper them from steroid, they can present it to the ED or ICU with myasthenia crisis or exacerbation. When the ED physician call you to evaluate a patient that possibly have myasthenia crisis, when you go there, you will look at the signs that give you red flag to accept the patient directly to the ICU for monitor in case they need intubation in the next few hours or few days. These signs are including ocular sign or bulbar sign. The ocular sign, you will see that the patient is not able to close their eyes very well, or we call it peak sign, or there is a curtain sign, which means when you open one eye, the other eye will close, and or there is diplopia, or there is eyelid droopiness. And in the bulbar sign, you will look at the nasal speech or difficulty in managing their secretions or chewing problem or dysphagia. You will look also to their breathe, If they have paradoxical breathe, which means if their abdomen movement is inward and instead of outward during inspiration, it means the diaphragm is already weak. There are also other tests that we look at, which is their cough. If their cough is already weak, it's a trigger that this patient already in the late stage. Also, you can test their neck extension and flexion. Usually, extension is weaker than flexion in a patient with myasthenia crisis, and they will have difficulty in maintaining their head up. There is also a test that we call one breath test, where we ask the patient to take a deep breath and then count numbers as much as they can in one breath. And if the number that they reach is below 25, this can give you a red flag that these patients have a low vital capacity, basically. There are tests that we can do by respiratory therapy. It's a NEF test, or vital capacity, that can be measured by a specific device. And it's the NEF is called maximum inspiratory pressure. And if it is less than a -20, it means they are impending intubation, basically. And if their vital capacity is below than 1 liter, they are also at risk of intubation. ABG is useful in these patients, especially the PCO2. We don't rely on oxygen saturation in those patients, because if they reach a point where they are desatting, they are already too late. And their basically crisis is in a very late stage. But usually in early stage we do ABG to monitor the carbon dioxide. They will return carbon dioxide before they desat. And sometimes we can help them with BiPAP before they reach a point where they need intubation. If the patient with myasthenia is already on methadone or neostigmine and they come to the ED with a crisis, we want to make sure to rule out cholinergic crisis before we start treatment. And there are signs that can tell you this is cholinergic crisis versus myasthenia crisis. The signs that we look at are diarrhea, sweating, lacrimation, basically increase in secretions, and there is point pupil, and there are vesiculation also, and we can rely also on the response of methadone. If the symptoms increase right after the methadone, then this is most likely cholinergic crisis. But if the symptoms increase at the end of the effective medication, which means before the next dose of methadone, then this is most likely myasthenia crisis. And we can also hold off the methadone and see if the symptoms improve, then this is cholinergic crisis. If the symptoms increase, then this is most likely myasthenia crisis. Let's say that the patient has all the bulbar sign, which means they have a nasal speech, they have difficulty in managing their secretion, and they already reach a point where their respiratory status is delicate, and their NEF is less than -20, and their vital capacity is very low. If they are already in BiPAP, I actually ask the patient if they need more help than that we provide for them, and they are the most useful tool. They will let you know if they are really in a bad shape. And we also monitor the carbon monoxide if the carbon monoxide is trending up, then the intubation is the next step. And when we reach this point, there are a few points that I want to highlight it during intubation. So when we want to intubate a patient with myasthenia crisis, we would like to avoid saline choline. And the reason for this, because they have already low acetylcholine receptors, and if we want to give acetylcholine, it might be under effective because they don't have enough receptor to depolarize the muscle, or sometimes because they are on a high amount of methionine, and which is the anticholine esterase. When we give them the saxenylcholine, there will be a prolongation in the effectiveness of saxenylcholine. That's the main reason that we are trying to avoid saxenylcholine during myasthenia crisis. So the preferred thing is rocuronium, and it's basically team. These rocuronium are not depolarizing medication, which means they only block the acetylcholine receptor, and it in myasthenia patient they need a lower dose because they don't have many receptors. And when the patient reaches the point where they need intubation, we usually stop neostigmine so they can basically manage their secretion better, and also because the patient will not need to eat, or even not need to be active much. That's why we stop neostigmine during the period of intubation. And also we want to point that we need to not give the patient a lot of sedation so they can use their muscle still and prevent the atrophy and basically more weakness of the muscle. Now I will talk about the main treatment that we use during myasthenia crisis. It's either IVIG or Plex. IVIG is intravenous immunoglobulin, or plasma exchange. It's used to do a plasma exchange more in the past before we discover IVIG. There are many studies that compare both of them. Both of them have resulted in similar outcome. The only difference that they point out is that Plex is work faster than IVIG, but in the final outcome is about the same basically. So there are side effects that we can point in each one, and in that way you can tell this patient need IVIG versus plasma exchange. So basically, plasma exchange is relatively contraindicated in a patient with severe sepsis or infection because you are removing all the antibody from the body, from the system basically, and the patient will be more prone to have more infection. And it also can cause hypotension because it's like a dialysis machine. Basically, you're removing a lot of fluid from the patient to clean it from the antibody and then put back the cells with the new fluid from the machine. And that's why they are also at high risk of bleeding, because we are removing all the factors that help on coagulation. So if the patient has high risk of bleeding, hypertension, severe sepsis, then we want to avoid a plasma exchange. And in the other hand, IVIG is relatively contraindicated in a patient with renal failure or has an MI, or even has an thrombosis like DVT, we want to avoid IVIG in these cases. The other advantage of IVIG is we only need peripheral IV for doing IVIG. That's why it's more available in most of the hospital. In contrast to the plasma exchange, it need basically a central line to remove the blood and clean it and then return it back. There are situations that um, we need plasma exchange more than IVIG. It's when the patient has anti-musk. If the patient has anti-musk, then most likely they will have bulbar symptoms and they have more severe crisis. So we need plasma exchange, and they don't think IVIG will work in this patient. I want to point out in this slide, after we start IVIG or plasma exchange by few days, you want to start them on steroid prednisone 40 or 60 milligram daily. And the reason that we want to do this is because if we don't start the patient in immunotherapy, then they will have rebound symptoms after completing the course of IVIG or plasma exchange. Steroid can worsen symptom in the beginning, but we have to start it after a few days of IVIG and plasma exchange, because otherwise the patient will not maintain their treatment. Regarding the other immunotherapy, azathioprine and Cellcept or rituximab, the patient might be already on this medication, and we can continue them or we can increase the dose, depending on the judgment and the cause of the exacerbation of the myasthenia. Usually the prognosis in myasthenia crisis is very good, and rarely they have mortality in those days, as we are now advanced in the treatment. Now I will move to the other topic, which is critical illness myopathy or neuropathy. Usually the typical scenario is basically a consultation to the neurology or a neurointensivist by an internal medicine ICU or other ICUs, stating that they have difficulty in weaning the patient from ventilation, although they already passed their critical situation or course, and they are improving in every way except that they have difficulty in weaning them from ventilation. There are several factors that can exacerbate the critical illness neuropathy, and these factors are basically related to the ICU course. If the ICU course is very complicated, they are at higher risk of critical illness neuropathy. Basically, if they are septic or if they had ARDS, they needed neuromuscular blockage, or if they have a disease that needed a steroid course, if they have hypoglycemia, or if we delay their nutrition, all these can exacerbate or put them at high risk of critical illness neuropathy. So when you get a consultation for this kind of patient, when you go there to evaluate the patient, you want to differentiate if this patient has critical illness polyneuropathy or critical illness myopathy. The more that you see those patients, the more that you can differentiate between the two of those types. There are a lot of patients that can present with both of those actually. During a clinical exam, if the patient has more motor issue and they don't have any sensory problem, then this is most likely critical illness myopathy. And critical illness myopathy has also high CK compared to the polyneuropathy. So you want to test also the CK in those patients. And the other also distinguished thing between the two is in a critical illness myopathy, you will see that they have more proximal weakness than distal. But in a critical illness polyneuropathy, they have distal weakness more than the proximal weakness. And in those differentiation is very important because the recovery of those patients is a little bit different. So in a patient with a critical illness myopathy, they have a better prognosis than a critical illness polyneuropathy, because critical illness myopathy, you might see the improvement from the first month or first 2 months, but a critical illness polyneuropathy, it needs more months to show the improvement. And the critical illness myopathy are more, they are more, they have more chance to recover to basically full recovery. But in critical illness polyneuropathy, there are kind of 30% of them end up with disability. And then the mixed type also end up with disability. So now I will talk about how can we diagnose a critical illness neuropathy. So the thing that I want to point out that those patients, they have a clear mind. Basically, they can communicate with you with their eyes. They don't have encephalopathy unless they have other factors that affect their brain. So their brain is normal in this patient. And also the second thing that I want to point out is the cranial nerve are intact in most of them. In a critical illness myopathy, sometimes they have some bulbar kind of symptoms, but in general, critical illness neuropathy, they spare the head from any weakness. And then the third thing that we can do, as I said before, is creatinine kinase. It's high in critical illness myopathy, but not in the other neuropathy. And the fourth thing that we can do is the EMG, which I will talk about in this slide. And then the fifth thing is the gold standard, is basically a biopsy of the nerve and muscle. And we can see the muscle necrosis in a critical illness myopathy, and then the axonal injury in the critical illness polyneuropathy. In EMG, we can differentiate between the myopathy and polyneuropathy, and also we can differentiate the acute weakness during ICU from other types, which means we can differentiate critical illness polyneuropathy from Guillain-Barré syndrome or from myasthenia gravis. So EMG is really helpful in this situation. And it's sometimes limited because not a lot of hospital can provide inpatient EMG. The way that we can differentiate critical illness polyneuropathy from myopathy is by doing SNAP and CMAP. And we can see that SNAP is normal in critical illness myopathy. And also in the EMG, we can see that the critical illness myopathy has myopathic pattern, which means the motor unit will be short and the amplitude will be low compared to polyneuropathy. And then the recruitment will have early recruitment in a critical illness myopathy. Unfortunately, we don't have treatment for those patients. So most of the management in those patients is only supportive. And we try to prevent it by avoid the risk factor that can lead to critical illness polyneuropathy. We noticed that critical illness polyneuropathy is underdiagnosed. This actually can result in about 30 to 40% of patients that spend their course in the ICU for about 1 week to have critical illness polyneuropathy. So it is underdiagnosed. And because a lot of these patients unfortunately die during the hospital course before they reach rehabilitation. But then when they reach rehabilitation point, they can recover fully in the condition of critical illness myopathy. And also, a lot of critical illness polyneuropathy, they can recover fully. Only 30% that can end up with a kind of significant disability, honestly. Most of these patients end up with tracheostomy and peg placement because the recovery course take a long time before they reach a point where they can be independent. We studied IVIG in those patients, and we didn't find that it's useful, unfortunately.
Thank you, Dr. Iman, for a highly informative session. Now we'll go with Dr. Bastian for question and answer.
Sure, welcome. Thank you, Doctor. So the first question we got is for Dr. Mohammed Mustafa, and it's a question by Mr. Santosh Kumar, and he asks, in a patient with GBS, right, if I started the immunoglobulins and there is an anaphylactic reaction, so do I stop? Do I have to stop the immunoglobulins and treat the anaphylactic reaction and then restart it? So that's a question for you, Dr. Mohammed Mustafa.
Yeah, that's a very good reaction. Thanks, Dr. Bastian. In these cases, one of the contraindications for IVIG is anaphylactic reaction, especially to the IgA subtype. And with this case, in this specific case scenario, would like to pause it completely and treat the anaphylaxis as it is. And in this case, it would be reasonable to re-challenge with Plex. But to re-challenge again with the same IVIG, I don't think it will be a safe idea. Unfortunately, there is no evidence regarding restarting doing IVIG again would be safer or not. But for history of anaphylaxis, it's a complete contraindication for IVIG to begin with.
Well, that's a very clear answer. Thank you. And we got another question for you by Dr. Mohammed Hassan. And he asks, if a patient has, on top of GBS, traumatic brain injury, so what would you recommend for the optimization ventilation management strategy?
That's a very
question, I would say.
Yeah, that's a very tough question because it depends on the context of TBI you are treating. Is it mild, moderate, or severe? Each has a different strategy of treatment. And in addition, is it TBI associated with ARDS or not, which is a very frequent accompaniment of this patient. But let's assume it's a mild traumatic brain injury, and the main branch is Guillain-Barré syndrome, which, by the way, some of the cases may be triggered by trauma itself. In these cases, I would target mainly the active process, which is the Guillain-Barré syndrome, and I will focus in this case on addressing the making sure he has enough good tidal volume and making sure that you have enough recruitment of the lung, augmenting the beep a little bit to prevent lung collapse. However, if the presentation is more like severe TBI and there is ARDS, I would be very careful. I would have to do the ARDS-NET protocol with low tidal and the protective lung strategy ventilation with the lowest driving pressure possible. So again, it depends on the clinical context. So I will see what is the predominant clinical feature, and I will manage the ventilator accordingly. I hope this answer was helpful.
Yeah, it was a difficult question, but I think you answered very well. And we also have a question for Dr. Iman. You're there, right, Dr. Iman, also live?
Yes, I am.
That's a question by Dr. Parvez in the Q&A, but maybe Dr. Parvez, you can type, you ask what is the prognosis, but what do you mean the prognosis of what exactly, like myasthenia, or can you be more precise in your question? And I would ask, as a neurologist, Dr. Iman, there is a recent publications on the newer drugs, right? That complement inhibitors like ravulizumab or eculizumab. What is your opinion on the newer drugs for from myasthenia gravis, should we not start earlier with those drugs because they are proven quite effective, I would say?
Yeah, these medications are very effective, and it's honestly a lot of patients started to moved away from the old immunotherapy to these because they have also a better side effect. I did not get touched to them because honestly, we rarely use them in the ICU setting. We most of the time we're just starting steroid, and then we leave this to the specialized neuromuscular neurology to deal with the switching from steroid to this kind of immunotherapy. We they don't recommend it to do it in the ICU setting because they have a lot to deal with, and when everything is cleared for them as an outpatient, it's better to know what's their baseline in terms of system function, liver, kidney, and then they can start this medication.
Okay, yes, very clear, very clear. Honestly, I do not have that much experience myself, so it's a relatively new drugs, I would say. Let's see, and there is one last question. There are not many questions tonight, so that means that the presentations were very good, I would say. One is by Dr. Antoine Cabeza, and he asks, what is the alternative in GBS? So this is a question for you, Dr. Mohammed. What's the alternative for immunoglobulins and plasma exchange as a treatment for GBS in the lower and middle income countries? Because not all countries have access, I would say. So do you have an answer to that?
That's a sad question. Unfortunately, we don't have any alternative. It's either IVIG or Plex. And actually, there are a lot of replicating trials on the fact that there is a significant mortality that can reach up to 20% in Bangladesh and Egypt and other countries of the world because of lack of delivery of the IVIG and immunotherapy in the proper time. It should be delivered within 2 weeks. And the only way to prevent it is proactiveness and preparation. Some places for institutional practice, because the Plex preparation is cheaper than the IVIGs, they do this. They do prefer Plex earlier. But unfortunately, without immune therapy, the prognosis of Guillain-Barré is going to deteriorate, especially in the first 2 weeks. So this is a research gap that I think should be addressed. And actually, the new drugs like Eculizumab and the Ergafitimigumab and all these monoclonal antibodies and IgG antibodies are addressing as an alternative to this, but again, they are expensive, as you earlier mentioned as well. So this is a research gap, a big research gap, and I think it needs to be addressed with future better trials.
Yeah, there's still a lot of health inequality, and that's something we should work on, all of us, right? So we do not have any more questions in the chat. So maybe Dr. Mostafa Gamal, do you have any closing remarks as chairman of the last 10 minutes?
Thank you, Dr. Bastian. And thank you all for joining today's session. I hope you enjoyed our webinar today. On behalf of our fellowship program, I would like to thank our speakers, moderators, and the participants, and see you next webinar, inshallah, and have a great day. Thank you, everyone.
Thanks, everyone.
Thank you. Bye-bye.
Thank you.